Uh, Before I get started, I just like to ask the audience just to get a sense of who is a neonatologist or a pediatrician take care of babies. Can you just show of hand how many people take care of babies here? Okay, we have few. Okay, so all the questions are directed to you from now on. Okay, let's get it started. I'd like to start with a case. This is a baby who was born at 24-week gestation by cesarean section, good Apgar scores. Baby was on conventional mechanical ventilation. The baby had received surfactant. Baby was hypotensive at the end of the first day. He was on dopamine, 15 mic per kilo per minute, and was weaned off all depressors once the baby received hydrocortisone on the first day. He got only one dose. Now, here is the echocardiogram of the baby, and what you see here, the red here, is the ductus. Ductus, left pulmonary artery, and maybe a little bit of right pulmonary artery. So this duct was 2.5 millimeter, and this is day one. For those who take care of babies, can I see show of hand who would treat the baby at this point? Anyone would treat a baby with PDA day one with this size ductus? Okay, nobody. Okay, they didn't treat the baby. This is day three. Again, same size ductus, nothing changed, but now the baby is on high frequency ventilation, not on a pressor still. So just increase respiratory support. At this point, who would treat this baby? Can I see a show of hand? Any of the, okay, we have few. Now they didn't treat the baby at day three. This is day five. Again, the same size ductus, 2.5 millimeter. And baby is still on oscillator, about 50% oxygen. Who would treat the baby at this point, including people who treated the baby on day three? So all who would treat the baby in the first 5 days, can you raise your hand, please? Okay. And they still didn't treat the baby. Now it's day 7. The duct is still 2.5 millimeters. It's still pretty big. It shows a little smaller on this slide because of the depths, the way that they measured the ductus here. So the baby wasn't treated for 7 days. And part of the reason that they didn't treat the baby was because the baby received hydrocortisone, and they were worried if the baby was to receive indomethacin or ibuprofen could result in perforation. But bigger part that they didn't treat this baby is because of the controversy nowadays that people are less aggressive with the ductus and would let the baby have a ductus for a longer time. Interestingly, at day 7, they decided to treat the baby with acetaminophen, Tylenol, and the following day, baby had GI perforation. So when you were thinking about whether to treat the ductus or not, you had in mind what was going on, whether PDA was contributing to the problem that you were seeing in the baby, that is, respiratory problem that the baby had, and you were thinking whether the flow through the ductus was putting the baby at harm way, and you're trying to assess the risk and benefit. And in other words, you were trying to see whether this ductus is hemodynamically significant. So in the next half an hour or so, we'll focus on how can we define a significant ductus. But before we get to that, let's talk about a little bit about the controversy. So this kid, if it was the baby was taken care of maybe 10 years ago, who would have been treated in the first couple of days, not wait for 7 days. And the reason for controversy is that over the last 10 years, there have been a lot of review article, not a lot of data, but a lot of review article casting doubt on whether we should treat the ductus. And if you look at the title of these review article, give you a sense on what's going on, whether the ductus is pathologic, how aggressive we should be, is the treatment beneficial. So all these cast a doubt on whether we should treat the ductus and how aggressively we should be. And the reason for controversy, in my view, are these four. One is that there is little information from randomized controlled trial. We don't know if the duct left alone in current era, what would end up happening to the baby. All the trials to date have treated the ductus in one way or another. In other words, we were trying to find out what is the best way to close the ductus, not whether we should close the ductus at all. So we don't have any information from randomized controlled trials. Second reason is that the prophylactic in the medicine where it was given, for example, in TIP trial, while it closed the ductus and reduced incidence of PDA and ligation, it had no effect at 18 months of age as far as neurodevelopment is concerned. And the third reason, just as in our case, the medication that we use to close the ductus has its own side effect. And finally, even in a small babies less than 1,000 gram or less than 28 week of gestation, a lot of them close their ductus. Up to 50% can close their ductus spontaneously during hospital stay, not necessarily in the first few days. So with that, it makes sense that we should be selective in whom we should actually treat the ductus. So when we think about hemodynamically significant ductus, we often either think clinically, the baby has pulmonary edema or not tolerating feed, is hypotensive, or we think in terms of echocardiography indices. Now, one thing that we don't take into account is the vulnerability of the baby. Although we know that gestational age has very much to do with whether the ductus actually closes or not, or becomes symptomatic, we tend to ignore it. At least in the last few years, that's been the case. So we know that premature babies, the extreme premature babies, they actually do not have the functional closure, or they're less likely to have functional closure, or the spasm of the muscle media in the PDA that is required for the ultimate anatomical closure of the ductus. So in babies, in premature babies, the wall is so small compared to a term ductus, and it doesn't have this vessel called vasovasorum, which supply the ductal tissue. So the oxygen supply to the wall is really dependent on oxygen in the lumen. So in the term babies, when the duct constrict, these vessels constrict. But here, even if the vessel constrict, there is no vessel in there, and all the oxygen comes from the lumen. So that makes the premature ductus less likely to have intense hypoxia in the wall that is a requirement to initiate anatomical closure. So it's no wonder that babies who are at extreme of gestational age and viability have bigger problem. Now this study is often quoted in the literature. It's about 10-year-old now, and what they did here is that they looked at the natural course of selected babies, those who didn't actually get treated, and looked when the ductus would close, if it was going to close. And about a third of these babies, less than 1,000 gram, they closed their ductus without any intervention. And if it did, it was in the first 4 or 5 days. What it doesn't tell you here is that when you look at the manuscript, at the paper, you see that they excluded babies who were less than 500 gram, babies who were 24 or less, and babies who actually died in the first few days after birth. In other words, they excluded the the most immature babies and excluded the babies who were sickest, the ones who are at greatest risk for developing a PDA. And when you look at the mean gestation, the one who actually closed their ductus, they had a mean gestation of 27, and those who remain open, they had a mean gestation of 25.6. This is a more recent study from France, also looking at the natural history of PDA. And what they did here, they followed about 100 babies, and they didn't treat this baby except for a couple of babies who got ligated. And they excluded babies who didn't survive past the 3rd day of life. And what they saw that when the baby survived the first 3 days, and if the duct was left alone, 73%, the majority of them, closed their ductus spontaneously. Now, if you read this paper more carefully, you see that although the author implies that PDA is not a problem and majority of them close on their own, they actually didn't highlight the certain problem that happens in these babies. So if we look at babies who died in the first 3 days, we see that 3 of them died of pulmonary hemorrhage, which we know clearly linked to significant ductus. So the ductus must have played a role in developing pulmonary hemorrhage and leading to death. In fact, a third or a quarter of babies who passed the first 3 days of life and survived also had pulmonary hemorrhage. And of those who died later on, if you look at the diagnosis or the cause of death, you see pulmonary hemorrhage, you see hypoxemic respiratory failure, NEC, IVH, multi-organ failure. All of these diagnoses can be linked to PDA, and PDA probably plays a role in the pathogenesis of these diseases. So this is one of the concern with the studies that actually disregard PDA as a benign and not a problem, because often they don't actually look at the other factors which are important. So in this study, they did not include babies who were 23 weeks, and the babies who were 24 and 25 only represented a third of the population. So majority of them were older babies. Again, highlighting the importance of the extreme. The babies who were 23, 24, and 25 weeks, they are very different than older premature babies. The second vulnerability, before even talking about the characteristics of PDA, is actually chronological age. How old is the baby? So let's look at this case. If we have this is a real case, a 24-weeker who has normal blood pressure, normal capillary refill time, he's on a low vent setting, good blood gases, and at 12 hours of life, the baby has this echocardiogram, and you see this large PDA, which is 3 millimeter, 24-weeker, 3 millimeter ductus. Now, this is a baby whom many of us may not treat the baby, or those of us who are more aggressive may consider closing the ductus. But in this baby, the cerebral blood flow was also compromised. So if we look at the surrogate for flow, look at the middle cerebral artery mean velocity, we see in this baby that the systolic velocity is low, diastolic is very low compared to normal. In other words, you have large ductus and evidence of low brain perfusion. They may not be related, but we could not rule that out. So in this kind of situation, you're more, I think, with that information, more of us would be inclined to close the ductus. And if we do so, we can look at this as a supporting evidence. So this is a study looking at the size of the ductus at 5, 12, 24, and 48 hours in premature babies, in babies who had normal superior vena cava flow. This is the median, this is the range for the babies with normal SVC. And the yellow shows babies with low SVC flow. We know that low SVC flow is a predictor of IVH. So these babies with the yellow, showing in yellow, are at higher risk for developing hypoperfusion of the brain and IVH. And what you can see here is that the difference in ductal diameter is really not later on when we clinically see the symptom of PDA, that is at 48 hours or even at 24 hours. It's really very early on. At 5 hours of age, you have the greatest difference. And the large PDA was an independent predictor of low SVC flow. So in other words, if we're talking about the vulnerability of the baby, we need to be specific in what organ we have in mind. So if we're talking about the brain, the vulnerability, the greatest vulnerability is probably the first day when you have the risk for IVH. And if we're talking, for example, about pulmonary hemorrhage, the vulnerability period is in the first 2-3 days when you have pulmonary hemorrhage. But when we're talking about NEC, BPD, if PDA plays a role in those pathogenesis, then it's likely to extend over weeks or months. So that's highlight the importance of gestational age and chronological age in determining if the ductus is significant or not. So what determines the degree of symptomatology of PDA? So if you have a PDA, why some PDA are more symptomatic than the others? One of the things that's important is the size. This has consistently been shown in many studies, time after time, that the single most important thing is the size. But that's not the whole story, as we will talk about it in a minute. So size, direction of the shunt, obviously you want to see left to right shunt. That's the right to left shunt are not the babies who actually have a problem with the signs of PDA. Duration of patency, the longer the ductus is patent, the more likely that the compensatory mechanisms that are in place get exhausted and you have symptoms. And the extent of the Steele phenomenon. So you may have very large shunt, but the left ventricle may be actually compensating for that shunt, and you may not see the effect of it. So if you don't have a lot of blood that is directed away from the systemic flow, the baby may still, at least as far as perfusion is concerned, may be okay. He may have a lot of blood going to the lungs and have pulmonary edema, but not systemic problem. So when we're looking at the echocardiographic evidence of hemodynamic significance, we can think about those in 4 categories. Category 1, it could be the shunt size. And to evaluate the shunt size, we would look at the diameter, the most important, and the flow pattern. And I'll talk about those in a second. The second category is the volume overload. To assess volume overload, we can look at the left atrial dimension against the aortic root. And we also can look at the amount of left ventricular output, which tells us also about the shunt. The third category would be assessing the pulmonary overflow. And for that, we could look at the left pulmonary artery flow pattern, and I'll talk about it in a second, where you have increased flow during diastole. And also looking at the LVA and LA-Ayo ratio would tell us about pulmonary flow. And the last thing, assessing systemic hypoperfusion. And for those, we would need to look at descending aorta flow to see if we have reversal flow during diastole, and looking at the specific organ flow, brain, kidneys, and the intestines. So here's the typical view that we look at the PDA. You identify the arch and you follow the ductus from the descending aorta to the pulmonary artery. And here you could see a view that would be good to have where you can see the ductus is in its entirety. So you have the pulmonary artery on the top, descending aorta at the bottom. Aortic arch is in different planes, so we don't see it. And here from the left side, you see the PDA, the left pulmonary artery, and the right pulmonary artery. So we need to look at the ductus and measure the ductus at its narrowest point. And that is that we need to see where is the ductus, not where is the flow, the maximum flow, because here we are in pulmonary artery, the ductus ends somewhere here. And then we would measure at the narrowest point, and that's what gives you the diameter of the ductus. The diameter of the ductus is pretty important, not just for what is the degree of the shunt, but also it can be predictive of who would actually develop symptoms. This is a very important study done a long time ago, where actually they looked at the PDA size at 5 hours of life in premature babies for different gestational age, and they plotted here the diameter. And what you see here are the red, the ones who end up not having PDA, and the blue are the ones who later developed symptomatic PDA. And the median for this group is 1.6. That's where the 1.5, greater than 1.5 diameter comes from when we talk about hemodynamically significant ductus. So if the ductus was less than 1.5, then the chances of that ductus becoming symptomatic was minimal to non-existent. When the ductus was greater, then it was more likely to be symptomatic, but it wasn't as strong as a negative predictive value of this measurement. It also, the diameter of ductus predict whether babies would develop pulmonary hemorrhage. And again, you could see the red dots are the babies who actually develop pulmonary hemorrhage, and you can see almost all except one, the diameter was greater than 1.6. The second important way of characterizing the significance is to look at the flow pattern. Many years ago, Sue from Taiwan described 4 patterns: pulmonary hypertension, growing, and pulsatile and closing pattern. And what you see in pulmonary hypertension, that you have either purely right to left, so let's below the baseline, or bidirectional, equally bidirectional. And these are the babies whom you obviously don't want to close the ductus because they have pulmonary hypertension. This is the growing pattern, where you have almost all left to right and very little difference between systolic and diastolic velocity. And the velocity is usually on the lower end. This is called growing pattern. And then you have pulsatile, where there is a big difference between systolic and diastolic flow velocity. And then you have closing, where you have high velocity and no difference between systole and diastole. And the two that are associated with hemodynamically significant ductus are the growing pattern and the pulsatile pattern. As a recent study looked at the flow pattern and looked at the diameter of the ductus. So you have here the different pattern, closing pattern, and so on, and the diameter. And what you can appreciate that yes, in closing pattern, the median is much smaller, the ductus, than the others. However, what I hope you can appreciate that the range is pretty wide. So you could have a closing pattern of flow, yet the diameter could be above 2 millimeters, which is significantly large. So they may be complementary and not using one versus the other. The other index of assessing hemodynamic significance is LA, left atrium to aortic ratio. And this is the oldest index. This was used back in 70s when echocardiogram was very primitive and you could only do M mode. So only you could look at the motion of the wall. So you could look at the aorta and the atrium, and you could see how big was the atrium relative to a structure which would not change in size if the volume changes, which is the aorta. So in other words, you were looking at the effect of PDA, not directly assessing the PDA. But it's still a useful tool. And when you look at the left atrium to aortic ratio, you would get a ratio, which in this case was 1.6. Most people use a cutoff of 1.4 to indicate a hemodynamic significant ductus. So in this case, the ductus was significant. The only issue is that if the LAAO ratio is small or normal, it doesn't rule out PDA, because you could have a large ductus and a lot of blood coming back to the left atrium, but have a fairly large PFO, so draining the blood to the right side of the heart. And those are the babies who are at actually greater risk, because you're taking away the compensation of the heart to pump, the left side to pump and overcome the shunt. The more newer way of assessing hemodynamic significance is looking at the left pulmonary artery Doppler. For example, this is a 34-weeker at 4 days of life with no PDA, and normally you should see only flow during systole with little to no flow during diastole, like in this case. This is a baby, another 33-weeker with a small left to right shunt, and you can see that there is a little flow during diastole, not significant. Another baby who's a 33-weeker, and this baby has a large bidirectional shunt very early on at 2 hours, but you can see how much blood going through the ductus during diastole. And of course, a 3-week-old baby who now have a lot of blood flow, large PDA, a lot of blood flow during diastole. And people use a cutoff of 20 centimeters per second to indicate if it's above 20 centimeters per second and end of diastole, like in this case, this would be considered hemodynamically significant ductus. Next thing to evaluate, again, these are additional things that typically your cardiologist would not look at, because they don't assess these indices, is the middle cerebral artery Doppler. This is the best approach in my view, because you look at the from temporal window, and you can see the MCA coming straight to your probe, which is the best way to look at the middle cerebral artery. You can look at the superior mesenteric artery and celiac artery, just under xiphoid process. And you can also look at the kidneys. And these are all, you could do it with your echo machine using the echo probe, and you can see the flow through the kidney. And then you can Doppler it. And as Dr. Lamnini showed you earlier when she was talking about the umbilical cord, the same things you would see here. So you would have a pattern that is pretty much in all vessels, to some extent is similar. You have systolic flow and you have diastolic flow, and they both should be forward flow. And forward flow meaning that it's above the line in this case when we're talking about these vessels. So abnormal flow shown here. Now you have small diastolic, and toward the end you have no flow. And then you could have absolutely no flow during diastole, and even worse, you could have reversal flow. So you could have flow that is below the baseline. That, I think, would give you additional information about whether this ductus is significant or not. Now, I'd like to end with a case and see what you think, what we should do about this baby. This is a 3-week-old baby who was born very premature at 24 weeks of gestation. He's on the ventilation, and his blood pressure is 36/19 with a mean of 27, and he's on dopamine 8 microgram per kilo per minute. BUN is 95, and creatinine is 1.7 milligram per deciliter. So the size of the ductus, as you see, is 2.5 millimeter. Here is the PDA. You can see the PDA flow pattern. So we saw the diameter. This is the flow pattern. This is the left pulmonary artery flow pattern. And based on what we just talked about, you could look at these and say whether this is significant or not. And the left ventricular output is 400, normal being around 200 to 230 ml per kilo on average. And the RVO is also about 400. So, what else I can tell you about this ductus? Let's look at the LA-Ayo ratio. In this kid, the LA-Ayo ratio was 1.24. So, given this information, the information I gave you, how many of you think that this is a hemodynamically significant ductus? Please. How many thinks that it is not, because our LA ratio is actually less than 1.4? So we all think that this is hemodynamically significant, and that's a good news, because I think when we're looking at the hemodynamics of the ductus and the clinical features, we need to look at the list of what direction the data is pointing. And these data may not always point to the same direction. Like LA-Ayo ratio was telling us that this ductus is not significant. But the ductus diameter and others were telling us otherwise. So if we look at gestational age, again, trying to summarize what we have talked about. So gestational age in this kid, this baby was 24 weeker. So among the premature babies, this still was a high-risk baby. The second thing, a chronological age, how old was this baby? The baby was 3 weeks old. So for more the big purposes, IVH, pulmonary hemorrhage, those things would be considered actually on the low-risk baby because it's not very acute. As far as respiratory support, the baby was on the ventilator at 3 weeks, so is a high risk. Baby was on pressors, so he's a high risk. Baby had some renal insufficiency. The BUN was elevated. The creatinine was high. And the PDA size was large, 2.5 for a 24-weeker is large. And the flow pattern was pulsatile, which is, we know that is associated with hemodynamically significant ductus. And the left pulmonary artery flow at the end of diastole was greater than 20 centimeter per second. And when we look at the left atrial to aorta, it was not high risk because the ratio was low. But if you remember when we talked about it just a few minutes ago, why this baby would likely to have small LA-Ayo ratio, well, when all the signs are actually pointing to hemodynamic significance, and you could probably guess that this baby has significant PFO, and that's why the baby also had high right ventricular output, because there was a lot of blood going from the left side to the right side and compressing the left atrium. So this baby was ligated, and you see here the blood pressure improved after ligation. This is the left ventricular output. Before ligation was 400. dropped to 175, which is still in the normal range. So it's expected for the cardiac output to drop because you removed the shunt. The right ventricular output also dropped from 400 to 300, but the drop was not as significant because, again, you have a significant PFO in this baby. And if we look at the middle cerebral artery Doppler, we could see no diastolic flow, and now you start having diastolic flow, although the systolic flow is lower than what it was. So when we talk about the brain, it's more complex. What about the celiac artery and SMA? Before and after ligation, you can appreciate what was the flow pattern of how it improved after ligation. And the same thing with renal, no flow to actually reversal flow during diastole to more normal pattern after ligation. So in summary, the controversy over the management of PDA actually should not result in complete dismissal of adverse hemodynamic effect of PDA, as some people tend to do nowadays. The hemodynamic significance of PDA should be interpreted by considering the gestational age and chronological age and the vulnerability of the organs in mind. So overflow when we're talking about the lung, hypoperfusion, brain, guts, and kidney, and we have to look at those individually and also put it in the context of the vulnerability of that organ given the time that the PDA is diagnosed. Is it day 20? If it's day 20, we're not worried about the IVH in this baby as much as if this was day 1. And finally, the assessment of multiple echocardiographic indices with organ blood flow Doppler are helpful in evaluating hemodynamic significance of the PDA. And I thank you for your attention and participating in the question.